Hello. I'd like to discuss the SDL titled Atherosclerosis. Atherosclerosis is a hardening of the arteries, specifically the large and medium arteries, due to the deposition of lipids and macrophages within the tunica intima of the vessel wall. Looking at the outline on the first page of this SDL, I've labeled with red Qs where I think the questions will be coming from on this exam. You can expect one, maybe two questions from the risk factors section, one from the pathology section, one, maybe two from the gross anatomy part of the pathology section, and finally, one or two from the pathogenesis section. So an atherosclerosis is a thickening of the arteries, and it occurs naturally over time in almost everybody. And as you increase in age, the chance or likelihood that you get atherosclerosis only goes up. Nothing seems to make it go down over time. The terminal events associated with atherosclerosis are thrombus and embolism. Primarily, a thrombus, or a stationary clot, can form on exposed subendothelial tissue whenever part of the clot lyses off. Secondarily, the clot that breaks off from the wall of an artery can travel downstream in the circulation and eventually occlude a smaller artery downstream. Atherosclerotic plaques also occlude and narrow the lumens of the arteries which they affect. This can compromise the oxygen perfusion of tissues downstream from the point of stenosis. And this is particularly damaging in high oxygen dependent tissues such as the heart and the kidneys. From the first page, what you really need to know off of this page is that atherosclerosis occurs in the tunica intima, and it particularly affects elastic and muscular arteries. So that's your large and medium arteries. We see that as we look at the epidemiology, in the 1900s, atherosclerosis only accounted for a single-digit percentage of all deaths. But nowadays, it's the #1 cause of death in America, accounting for almost 1 in 5 deaths, almost 1 in 4. Ischemic heart disease is a very common condition characterized by an inability to supply blood to the myocardium. And atherosclerosis immediately predisposes one to developing ischemic heart disease. The last interesting sentence from this section to me is that atherosclerosis is much less prevalent in Central and South America, Africa, and parts of Asia. That lets me know that it's something in our lifestyle, including our diet, that is directly responsible for the nearly 15% increase in atherosclerotic deaths in Americans over the last century. The SDL then transitions into a discussion of the risk factors for atherosclerosis. Now, risk factors are particularly board relevant. And the reason why risk factors are board relevant is because the pharmacological management of atherosclerotic patients is often determined based off of their score on a risk assessment, meaning that we have statins and other lipid-lowering therapies with various efficacies. Some are very potent and very strong, and others are less strong. So we want to use the big gun statin and lipid-lowering therapies on the patients with the highest risk for adverse events. And typically the risk is for heart attack within 10 years or development of ischemic heart disease within 10 years. So because you're going to be screening your patients for their atherosclerotic risk on a very consistent basis, almost no matter what your specialty is, but especially if you're in the primary care fields, you're going to need to know what the risk factors for atherosclerosis are so that you can talk to a patient and immediately know in your head, okay, this is a high risk individual versus a moderate risk individual versus a low risk individual before you even go to input their data into a calculator. And there are calculators for risk factor because risk is such a multifactorial process. Namely, there's the Framingham Risk Assessment Calculator, which is almost universally used in America today, and it takes into account most of the risk factors listed in this SDL. So you need to know the risk factors because they will be boards tested, and they will be boards tested because the pharmacotherapy of atherosclerotic patients is determined by where they stand on a risk assessment scale. So you will be performing that risk assessment throughout your career. The SDL at the bottom of page 3 talks about the criteria of causality, and this is not particularly important to memorize for our in-house exams, but I want you to know that the specific criteria of causality laid out here are historically important because these are the same criteria of causality used by the Surgeon General to determine smoking as causal to lung cancer. I want to repeat that. The criteria listed here are historically important because back in 1964, when the Surgeon General says smoking leads to lung cancer, the objective or empirical or scientifically valid way that we knew that to be true was because the epidemiologic assessment of smoking passed all of these criteria. Therefore, because it passed these criteria, we said smoking plays a causal role in the development of lung cancer. So that's a bit of a historical novelty there. It doesn't really apply to this exam, though. You won't get tested on the definition of a risk factor. You might, however, get tested on the risk factors for atherosclerosis, which I have outlined in this table 2 in red. And this is an important table to note because in a couple of pages, we discuss some risk factors which have not as of yet been strictly identified as directly leading to atherosclerosis, meaning they're probably true risk factors, but we don't include them in risk assessment as of right now. So boxed in red on this page in table 2 are the risk factors that feed into risk assessments. So if you get a question that asks you to name the number of risk factors that a patient has, you ought to be going off of table 2, right? And if you get a question that says, what's the non-modifiable risk factor in this patient, then you ought to be going off of table 2. And then if you get a question that says, patient presents with atherosclerosis, what's their modifiable risk factor? Then you ought to be going off of table 2 here. And notice, if you will, that obesity is not included as a risk factor of atherosclerosis. And also notice that a sedentary lifestyle is not an explicitly delineated risk factor of atherosclerosis. So some things that you may be prone to say, oh, for sure obesity leads to atherosclerosis. Nope, that's not going to get you the question right on an exam, not on our VCOM exams and not on the boards either. So going into constitutional risk factors, which are those you cannot do anything about. Number 1 is age. It's the number 1 risk factor overall for atherosclerosis. And the reason that we know it is number 1 is because the prevalence of vascular disease increases significantly with each decade of life, period. It never goes down. There's no way you can reverse it. It's always going to get worse, and it happens to everybody. So therefore, individuals in the 90th to 100th year of life have a 1 in 3 chance of an atherosclerotic event occurring, or vascular disease, I should say, as opposed to a 2% chance within individuals in the 40 to 50 age bracket. The second most important non-modifiable risk factor is gender. And that's because the male gender has such a predisposition to atherosclerosis that they develop it on average 10 years earlier than women. And the reason why women have a protective effect is because of estrogen. And 55, which is when women get atherosclerosis on average, happens to correspond with menopause, when the body stops to release estrogen. Now, estrogen acts namely by lowering HDL. And all of the other protective effects of estrogen seem to be downstream of this pro-HDL effect. We know that HDL is the reverse cholesterol transport mechanism that takes lipids from foam cells and transfers those lipids to the liver so that those lipids can be excreted in bile. So if you have more HDL, it's protective against atherosclerosis. So the female gender is a very significant protective factor, or rather, should I say the male gender? Man, us guys, we're unlucky, you know. Genetics also plays a big role in the development of atherosclerosis, and my takeaway from this paragraph is the definition of a positive family history. Because it's not just, oh yeah, my dad had a heart attack or my brother had a heart attack. No. They have to be younger than a certain age, and that's 65 in women and 55 in men. So if the event presents younger than this age threshold, that's a +1 in their risk factor assessment. Now let's get into the modifiable risk factors. The most significant modifiable risk factor, meaning a target that we can change therapeutically most often, is hyperlipidemia. And I want you to know that if a patient has high LDL, high VLDL, and low HDL all at the same time, it still only counts as a +1 in the hyperlipidemia box. It only counts as one risk factor, even if they have multiple different lipids that are off. So low HDL is going to give you a hyperlipidemia profile, but a high HDL is going to be protective. And that's the big takeaway from this whole section, is that HDL cholesterol, when it's above 60 milligrams per deciliter, is a negative risk factor in the Framingham assessment. And that means that it's the only possible thing that you can have your patient do, or that you can do as a physician for your patient, to get them a -1 on their risk assessment. And that can be significant if somebody is threshold. Finally, there's a discussion of triglycerides, but it's relatively vague. I don't see a question coming from that paragraph on triglycerides. Another modifiable risk factor is hypertension. And this is where things start to get biochemical, because Santo has listed 2 mechanisms for the development of atherosclerosis secondary to hypertension. And that's number 1, the impairment of nitric oxide production. And number 2, the expression of cellular adhesion molecules on the surface of the endothelium. And I'm going to break those down very quickly. Nitric oxide is a vasodilator. And whenever you have an atherosclerotic plaque within a lumen, what it does is it reduces the size of that lumen gradually over time. And everything downstream from that plaque is going to gradually become hypoxic in proportion to the occlusion of that lumen upstream. And nitric oxide will begin to be released by smooth muscle cells within the wall of the artery that's impacted by atherosclerosis, in order to compensatorily vasodilate that artery, so that the tissues that are downstream of an atherosclerotic plaque can continue to receive the same amount of oxygen as they did before the plaque even started to develop. So nitric oxide is a vasodilator. Hypertension causes a lack of nitric oxide, thus it vasoconstricts that lumen even farther, which is a bad thing for the downstream tissues. Next, I'm going to talk about the expression of cellular adhesion molecules. Atherosclerotic plaques involve macrophages. And before macrophages get into a tissue, they're called monocytes. They're called monocytes when they're circulating in the blood. And these monocytes get into the blood by means of the bone marrow, because that's where your hematopoietic stem cell lineages are. And a monocyte is a white blood cell. And a monocyte is going to float through the blood until it detects chemotactically a region of damaged tissue. And it is going to flock then to that damaged tissue and become a macrophage. Well, not really become, but we call it a macrophage when it's in tissue. And what it's going to do is it's going to find the damage. And it's going to find the damage because the macrophage expresses certain receptor proteins on its outer membrane that allow it to grab hold of anything that's damaged and bring it into its cell body. And then when it does that, it's going to try to kill it if it can through free radical mediated killing, or if it can't kill it, it's going to probably apoptose itself or call in some cytotoxic T cells that can kill whatever the injurious stimulus is. So in the case of atherosclerosis, the injurious stimulus is going to be oxidized lipids, right? So in order to clean up oxidized cholesterol, which your endothelial cells, your smooth muscle cells, they can't do anything with that. You need macrophages to just vacuum all of that up and do something with it. And the way that you get macrophages into the intimal space is through the expression of VCAM on the surface of an endothelial cell. And VCAM is a beta-2 integrin that is going to mediate the attachment of a monocyte to the wall of a blood vessel and allow it to roll on across that wall and eventually go through the extravasation process and enter the tissue of the artery and then start to mop things up. So anything that is going to increase the expression of VCAM, as in this example, hypertension, is going to also increase the content of macrophages within the tunica intima of these medium and large arteries. And that is going to promote atherosclerosis. Then we move on to cigarette smoking. This is a modifiable risk factor, and this is fortunately a very modifiable risk factor in the sense that after 2 to 3 years of not smoking, your level of risk as an ex-smoker is identical to a never smoker. That's really good news. Smoking interacts with cells by causing platelets specifically to secrete platelet-derived growth factors. So cigarette smoke causes platelets to secrete PDGF, which is then going to bind to growth receptors on smooth muscle cells in the subendothelium and induce hyperplasia within those smooth muscle cells. And as we will see, smooth muscles play a very multifaceted and direct role in the pathogenesis and expansion of an atherosclerotic lesion. So anything that activates platelets and induces platelet growth is subsequently going to increase vasoconstriction of a lumen. And it is also going to increase the expression of collagen and tissue factor that gets spit out by a smooth muscle cell into the extracellular space. So that's what platelet-derived growth factor does as a result of cigarette toxins in the blood. And also cigarette toxins will upregulate VCAM1 and other cell adhesion molecules on the surface of the endothelium. That is a theme that we will see repeated quite frequently throughout all of this SDL, is the VCAM expression as a sign of endothelial damage. And diabetes, finally, is a risk factor. Technically, it's a risk factor. It's no longer a risk factor on Framingham. It used to be, but some recent studies have shown that only type 2 diabetes is a risk factor, and type 1 diabetes does not seem to directly contribute to atherogenesis. So they're kind of in the process of figuring out what to do with diabetes. As well, you have metabolic syndrome, and well, the big question is, should we just lump all of these risk factors in under metabolic syndrome and say, if you have metabolic syndrome, then you have a +3 risk factor rather than a +1 for this, +1 for this, +1 for this? Because let's be quite honest, these conditions tend to present simultaneously, meaning that if you have a bad lipid profile, you're more likely, correlation not causation, to have diabetes. And you're also more likely, correlation not causation, to have truncal obesity. So again, that's where we're at in the field, is should we just call metabolic syndrome a thing and make it a risk factor on its own? And then we get into some additional risk factors. And for purposes of this exam, I believe, and I will have to double check this, and I will double check this with Dr. Colson and get back to you with an answer by the time we take our test, but I believe that if you get asked to count the number of risk factors a patient has, then these will not factor into that count because they are not legitimate or endorsed risk factors. First off, we have C-reactive protein, which, you know what C-reactive protein is. CRP is produced by the liver, and it's an acute inflammatory marker. And it's a marker because it tells us that something is up, but it doesn't tell us what is up. Well, it turns out that it has a little bit more of a function than simply acting as something we can interpret in the blood. It may act on endothelial cells to cause them to upregulate adhesion molecules and to cause them to produce chemoattractant cytokines, which, remember, we said that monocytes get attracted to very particular areas of damage, and that attraction is mediated by the release of soluble cytokines from damaged tissue. And so CRP may directly stimulate injured endothelium to let off those chemoattractant chemokines, namely going to be the interferon gamma, going to be your TGF beta, might be your TNF alpha, might be your IL-8 for some neutrophils, and those are going to be the specific chemotactic factors that start to attract immune cells to this localized injury. Next, we discuss homocysteine, and homocysteine is included in the atherosclerosis SDL in the light of homocysteinuria, of which atherosclerosis and subsequent thrombosis is a frequent complication. Now, homocysteinuria is an autosomal recessive disorder that is a knockout of the cystathionine B synthase enzyme, and patients with the cystathionine beta synthase defect are not going to be able to make high amounts of cysteine. And what this means is that, well, cysteine participates in disulfide bonds. So if you can't make enough cysteine, then that means that a lot of proteins which require disulfide bonds to adopt a particular conformation are not going to be able to function. So this failure of structural proteins due to a lack of disulfide bonds explains the ectopia lentis and the marfanoid habitus, the Marfan-Light syndrome, seen in a homocysteinuric patient. Speaking solely to the endothelial interaction of homocysteine, we believe that homocysteine causes endothelial damage by inhibiting thrombomodulin on the surface of endothelial cells, thus making them more prone to clotting. As we know, the clotting cascade begins whenever factor VII binds to exposed tissue factor. And tissue factor is only expressed by subendothelial smooth muscle cells. And I want to say that one more time. Tissue factor, which is what factor VII binds to start the clotting cascade, is not expressed on the surface of endothelial cells. Otherwise, you'd be having clots all over your body at all times, you know. It's only expressed on subendothelial tissue, which means that whenever there's a vascular injury to a particular point in the endothelium, the subendothelium gets exposed, and then a clot will form there immediately to tamp down the damage and to patch that hole. That's why tissue factor is selectively expressed on subendothelial tissues. So whenever a clot does occur, there's a process of remodeling that happens as you tell the clot, whoa, 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 you're big enough already. Stop clotting. And this is important because if you aren't able to tell a clot that, it's just going to keep getting bigger and bigger and bigger, and that whole lumen is going to become obstructed if you can't cut it down to size. So thrombomodulin is an antithrombotic that tells these platelets stop aggregating, and that tells these clotting factors will slow down, and it will reduce the size of the clot so that it's manageable and flat on the wall of an endothelium. And if you can't do that due to an inhibition of thrombomodulin by homocysteine, then you're at a greater risk for large vessel occlusion. And as a result, almost a quarter of patients with homocysteinuria are prone to death as a result of thrombotic complications. Moving on, we've got lipoprotein little a. And it's called lipoprotein little a because you already have a lipoprotein big A. That's ApoA that's expressed on the surface of HDL particles. And so because you already have an apolipoprotein A, we call this apoprotein little a. So LP little a is a significant heritable risk factor for the development of atherosclerosis. What LP little a is a modified form of low-density lipoprotein. And essentially that means it's a modified form of the ApoB protein. And what it looks like, I've illustrated here on the left side of the page, it is essentially a normal ApoB100 that is covalently linked to the apo(a) extra protein. And this apo(a) should not be on your ApoB. When it is on your ApoB, What that means is that it is more difficult for ApoB to slot into the LDL receptor and conjugate itself to the active site of that receptor to activate it. And it's more difficult for ApoB to conjugate itself to the receptor because its receptors have a lock and key format, right? And ApoB is the key. And so if you take a key and you take some putty and you put some putty on the key, the putty being apo-a, the key's not going to fit in the lock anymore, you know? So the degree to which ApoA is manifest in a patient's blood coordinates with the impairment experienced by ApoB when it tries to bind the LDL receptor. And if you can't get the ApoB on your LDL particles to bind to the LDL receptor, then you cannot get those LDL particles out of your bloodstream, because the only way, bar none, for an ApoB100 carrying low density lipoprotein to make it out of your circulation is to bind to the LDL receptor and get endocytosed into a cell, most typically the liver. And so the reason why LDL is your bad cholesterol is because when LDL doesn't bind to the LDL receptor on the liver, it just keeps going around and around and around and around in the bloodstream. And this increases as a sheer function of probability the likelihood that LDL is going to migrate into the subendothelial space, into that tunica intima, and become oxidized within. So lipoprotein(a) is a modified form of ApoB, thus it is a modified form of LDL. So lipoprotein(a) is more prone to getting stuck within the tunica intima because it is less prone to LDL receptor binding. And finally, lipoprotein(a) has a direct inhibitory effect on fibrinolysis. So not only are you more likely to generate these atherosclerotic plaques to begin with, but you are also less likely to be able to stop the clotting cascade due to the antifibrinolytic effect of apoprotein(a). Finally, the last modifiable risk factor we discuss is Chlamydophila pneumonia, and this one is really simple. Chlamydophila is kind of a cousin of chlamydia. It's got a different name now, but what you need to know about chlamydia is that they're obligate intracellular, meaning they're nothing if they don't have a cell to float around in, right? And specifically, they're nothing if they don't have a macrophage to float around in, because monocytes travel around in the blood. So this is how Chlamydophila infection disseminates through the bloodstream, is by hitching a ride on the monocyte bus. And when the monocyte happens to deposit itself into the tunica intima of a medium or large artery, because there was oxidized LDL in there, and because there was endothelial damage that upregulated VCAM expression and got that monocyte into that tissue, well, Chlamydophila is going along for the ride. And so when that monocyte becomes a macrophage within the wall of that large artery, Chlamydophila is there to infect the endothelium and the smooth muscles within that space. So that's very, very bad. And Chlamydophila does not directly lead to atherogenesis, but it promotes it by means of slowing the rate at which the cavities created within a tunica intima heal over time. So that's Chlamydophila. Now let's get into the pathology of atherosclerosis. Looking at this image, this is a very good image. You ought to know this image in its entirety. First off, LDL gets into the subintimal space. That's the first thing first. And the reason why LDL gets into the tunica intima is because LDL is small enough to fit into the gap junctions between cells in this fenestrated endothelium. And the reason why LDL is your worst cholesterol, I mean the most despicable cholesterol, why is it not VLDL? Why is it not IDL? Why is it not chylomicrons? And the answer to that is because the density of a lipoprotein is inversely proportionate to its size. So as a lipoprotein becomes more dense, it condenses, right? Literally, and it gets smaller. And so a VLDL, oh, that's a big boy, you know. That's like Jupiter. Jupiter's not getting through that hole in the LDL or in the endothelium, you know. But LDL, that's a little bit smaller, you know. That's more Earth size, let's say, that can fit through the endothelium. And then HDL, that's your highest density lipoprotein. And man, that thing's like a golf ball. Of course, that's getting into the endothelium. So your LDL can get into the subintimal space and your HDL can get into the subintimal space, but your VLDL is too damn big to fit in there. And so it doesn't. So your VLDL does not directly get oxidized within that space, and it does not directly cause atherosclerosis. That is the reasoning behind LDL as the definitively atherosclerotic, atherogenic cholesterol particle. So what happens when that LDL gets oxidized? Well, before I talk about that, let's ask, how does that LDL get oxidized? Well, the answer to that is that it's just stress. You got to look at it generically because so many different things can cause oxidative stress that it is useless to try to count them, you know? So what you need to say to that is just stuff that generates oxygen radicals can oxidize LDL. Okay, fair enough. And one of those things happens to be this enzyme 15-lipoxygenase, and that may be part of a test question on our exam, but as you go out into the clinical world, know that anything floating around that is already radicalized can transfer that radical to a free LDL and generate ox-LDL. So what on LDL gets oxidized? Well, remember that LDL is a sphere of amphipathic phospholipids that have a hydrophilic outside and a hydrophobic inside. And that outside of the LDL particle, that's what's going to get oxidized. Because what? Something's going to oxidize the dead center of it? No, I don't think so. It doesn't have access to the center of it. It can only oxidize what it can touch, and it can only touch the outside of this LDL particle. So phospholipids and maybe some free cholesterol in the spherical membrane of this low-density lipoprotein particle are what get oxidized by various free radicals floating around in the blood. And oxidation occurs specifically in the subintimal space. And the reason for that is because you've got so many antioxidants floating around in your bloodstream that there is no way that an LDL particle gets oxidized in your blood. You've got vitamin C, you've got other protective molecules and enzymes, you've got several minerals that can sponge that, you've got the glutathione peroxidase conjugation system within your red blood cells. Remember that GSSG? Man, that thing sees a free radical and it just whoop, out like a light, like no free radicals in the bloodstream. You got it? So it's only going to occur in the tunica intima. Where we go next is, well, this oxidized LDL just stacks up on each other and it aggregates and it forms these dense crystals because that's what cholesterol likes to do. It likes to stack up on each other, and that's what lipids like to do because they're hydrophobic. So they cling to one another and they stay with their in-group because they're scared of the water. They do not want anything to do with the water. So they form clumps and aggregates. And when they do, those grow and grow and grow and grow. And eventually you have to do something about them. And how do you do something about them? You call in your macrophages. And macrophages have scavenger receptors that specifically bind to oxidized LDL particles. And these scavenger receptors will mediate the endocytosis of oxidized LDL. And so you will be able to decompose these clumps of LDL within the subintimal space, one lipoprotein at a time. And that's what the macrophages do. And as they do that, they retain some of the lipids that they eat within their vacuoles, and they become a foam cell in the process. That's where we're at now in this diagram. Now, the final key point out of this entire page is that high-density lipoprotein is directly responsible for accepting lipids from foam cells and transporting those lipids back to the liver so that they can be excreted in bile. And high-density lipoprotein does this by binding to an efflux transporter on the surface of a macrophage. And that's going to be your, I think it's ABCD, ABC something, you know, it's in the hyperlipidemia SDL, and the HDL is going to bind to that with its LCAT. So LCAT is in the HDL particle, and LCAT stands for lecithin cholesterol acyltransferase. And what LCAT does is it's going to esterify these cholesterols. And when you esterify a cholesterol or a lipid, then that means that you put an oxygen on the end of it and you attach that to a carbon of some sorts. And when you esterify a cholesterol or any lipid, that means that you can store it within a lipoprotein and transport it back to the liver. So whenever you esterify all of these foam cell lipids, you are effectively saying goodbye tunica intima, hello liver, with all of those fats, and then the liver can push it out of the body. So that's what's going on with the picture of atherosclerosis at the cellular level. Let's zoom out a little bit more now and talk about some atherosclerotic prone areas. Specifically, they're going to be areas of low shear stress. And when we say low shear stress, we are referring to, by shear, the degree of frictional force moving against the endothelial surface tangent to that linear surface. Now, low shear stress is characterized by turbulent flow. High shear stress is characterized by laminar flow. And that's because shear stress, again, is a tangent force, and laminar flow proceeds with a parallel direction to the direction of endothelial cell linings. But turbulent flow can have a multidimensional vector behind it, and so it's going to press directly against, in some angle, against these endothelial cells, and that's what makes it low shear. So the turbulent flow is a low shear flow. And where are low shear flows encountered? Well, they're encountered at the branch points of large vessels, specifically the bifurcation of the carotid artery. And that's right up here on C. And they're specifically also encountered at the branch points of medium arteries off of large arteries, and that's what A is referring to. And then finally, you can get them quite frequently at the aorta, because along the inner wall of this aorta here, you see that there's a lot of turbulent flow passing over that curvature, because the flow goes up and it doesn't want to stick to that curvature, and sticking to the curvature is kind of what makes it laminar. So I'm not sure what sort of test question may arise out of this gross anatomy discussion, but I feel as though you will be able to adapt to and successfully answer it no matter what it is, because all of these arteries are things that we've seen before. Finally, we're looking at the effect of turbulent flow on the endothelial cells. This is a really busy paragraph with lots of big words, and I would condense it by saying endothelial injury is characterized by 4 things: hyperplasia, macrophage proliferation within the endothelial boundaries, constriction of the lumen, and clotting. So you've got, again, proliferation of endothelial cells in response to stress, expression of cell adhesion molecules in response to stress, failure to generate nitric oxide synthase in response to stress, so that's your vasoconstriction, and then finally, focal platelet adhesion in response to stress, that's your clotting. Now we get into the gross morphology of atherosclerotic lesions, meaning if you were just looking with your own 2 eyes at an atherosclerotic plaque, what does it look like visibly? And I believe that there is going to be one question about the gross morphology of a plaque, or what it looks like visibly, and I believe that there is going to be another question about the complications of a plaque downstream. So let's get in it. A fatty dot is exactly what it sounds like. It's a dot made of fat. And the question that I have seen in practice texts is going to be, here is a picture of atherosclerosis. And then the atherosclerotic lesion is going to be in one of these 6 stages of progression. And then they're going to ask you, what would you expect to see on a histology slide of this gross lesion? And you're going to have to say, well, I would expect to see, lipid-laden macrophages with no extracellular lipid. And that would be the correct answer for a fatty dot. And so you'll see that as we move through the types of gross lesions, the histology of a dissected lesion changes. So a fatty streak, same thing as a fatty dot. You see macrophages, you see a few lymphocytes, you don't see any extracellular fat. That's big. Moving on to an intermediate lesion, or a pre-atheroma. You will see extracellular lipids in a preatheroma or a type 3 atherosclerotic lesion. And that's what differentiates it from a type 2 fatty streak. Moving on to a type 4, the atheroma. Types 4, 5, and 6 have a lipid core. And so that's the buzzword that you're looking for in an answer choice is the lipid core. And if they show you a lipid core and they say, what is this? Then it's going to look similarly to the upper right-hand side here. It's a massive single solitary aggregate of lipid, not individual little clumps within a cross section of a vessel. That's important too. You can't really tell if it's a lipid core or not if you're looking, straight onto the side of the vessel, unless it's notably profound. That was terrible verbiage on my part. So an atheroma has a lipid core. Specifically, it's a necrotic core because of all the dead macrophages that got poked open by sharp cholesterol crystals, and they just eventually died of the toxicity. But the intima of an atheroma is still the normal intima. You do not see any intimal changes. The atheroma, however, is a kind of bumpy. It's a little bit raised above the flat normal surface of the intima. Finally, atheromas are pale yellow. That's how you make the diagnosis of that versus a fibroatheroma, which is going to be white in color due to the fibrous cap and collagen tissue expressed immediately on the surface of the fibroatheroma. So we realize we're going to see a white collagenous lesion with a smooth surface. Note again that atheroma is a yellow lesion, although both present as large bumps protruding into the lumen. And there are also many smooth muscle cells on the histology of a type 5 fibroatheroma lesion. And finally, something that separates a fibroatheroma from a regular atheroma is the development of capillaries at the margins of the lipid core. So the lipid core is in the middle, and then there's capillary growth around it in an attempt to perfuse that oxygen-deprived space. Finally, we move on to the complicated plaque, and the complicated plaque is simply the plaque with complications. And listed in this subsection are 4 complications, which makes me prone to believe that there are 4 answer choices that there are 4 answer choices here, basically. I don't know why I'm being so long-winded. 4 answer choices. The plaque can calcify, the plaque can rupture. You can get a cholesterol embolus, you can get a plaque hemorrhage. You might be shown a cross-section of an artery and the macrophages are all rusty brown. And then the question could be, what complication occurred here? And you got to know, it's got to be a hemorrhage. It's got to be an acute bleeding because those are hemosiderin-laden macrophages that just digested a bunch of red blood cells. You could get shown a calcified lumen and have to know that it's dystrophic calcification. Finally, going back into the pathogenesis of a ruptured plaque, what happens is that the plaque is protruding into the lumen. The flow of blood knocks the plaque off and displaces it. So where the plaque used to be, all of a sudden, there's a bunch of subendothelial tissue. And on the surface of that subendothelial tissue is this thing called tissue factor, which binds to factor 7 to initiate the clotting cascade in blood. That's how you can get a clot on top of a plaque. And the rupture, of course, can go downstream, and that's called an embolus, and it could occlude a smaller artery. And specifically, this is prone to happen in the lower half of the body because that's downstream from the large and medium arteries you expect to see atherosclerosis in. And so they are going to manifest symptomologically as possibly a numbness of the foot, possibly a blue or cyanotic foot, possibly a gangrene of the toes, maybe a lack of peripheral pulses. And finally, livido reticularis is a particular rash that is associated with hypoxia of the lower extremities. So let's get into the pathogenesis of atherosclerosis. There are a couple of really good paragraphs here, but the majority of this particular section should be things that you're already familiar with, generally speaking. I do like the paragraph on lipids saying that hypercholesterolemia is directly responsible for free radical production, which is going to impair nitric oxide release, which is going to constrict that endothelium. And the stress on the endothelial cells causes the expression of VCAMs and cell adhesion molecules. Gradually, macrophages will start to endocytose the oxidized LDL, and atherosclerosis is all downhill from there. So that's a really good summation paragraph. The paragraph on inflammation, anything inflammation is so generic, that's never going to be your therapeutic target, because how do you measure it, So I kind of glossed over that. I do think it's important to note, again here, that the thrombi that cause fatal acute MI are there because of a disruption of the plaque, because you don't get the clot until the plaque breaks off. And that's because tissue factor is not expressed on the surface of the plaque. It's only expressed on the subendothelial tissue, which gets exposed when the plaque ruptures and breaks off. And that's stated in very clear language immediately underneath: tissue factor expression by plaque macrophages. So you need to know that the cells upon which a clot starts are the macrophages and smooth muscle cells beneath the endothelial layer. The clot doesn't start on endothelial cells. It starts on macrophages and smooth muscle cells. Then finally, there's this there's a section on smooth muscle proliferation that I believe you could see a question on, because smooth muscle proliferation is one of the hallmarks of mid-stage atherosclerosis, and how it contributes to the symptoms that you see is that the smooth muscle cells proliferate, and that causes a vasoconstriction. And remember that the smooth muscle cells also have tissue factor on them, and so that's a risk for a clot. But then finally, smooth muscle cells immediately contribute collagen to the extracellular matrix, and so it's going to make the walls of that blood vessel harder, more tougher, more dense, and that's why it's called atherosclerosis, right? Is because that means arteries got hard. And how do they get hard? Collagen. Where did the collagen come from? Smooth muscles. That's it. So smooth muscles have the potential to lay down collagen when they are stressed. It's not something they normally do, but because they come from the same lineage as the fibroblast, and the way that you know this is that they're both spindle-shaped cells. They're both morphologically similar. So you know that when they're in a pinch, the smooth muscle cell absolutely has it within its genetic capabilities to upregulate the enzymes necessary for the synthesis and output of collagen to the extracellular tissue. And it does this as a direct response to stress. So that's a really cool factoid about smooth muscle to me. And I think that that's something that if you don't see it on this test, you could quite possibly see it on boards, because only a limited amount of cells can just shoot collagen all over the place. And we know that collagen plays a very important role in scar tissue formation, and thus in the impairment of function of various organs in which scar tissue develops. So moving on now to the clinical picture of atherosclerosis. This is the last part of the SDL, and it can present in some select areas. Not everywhere in your body is prone to atherosclerotic events. Coronary artery atherosclerosis may directly lead to ischemic heart disease. We have an entire SDL on that. Atherosclerosis of the carotid arteries. Well, you could get an embolus of the plaque, and that could include artery in the brain. Or you could get a thrombus that forms atop the tissue factor whenever that plaque breaks off. And then the thrombus could get pushed off into the blood, and then that's a thromboembolism, and that could sure get to the MCA, the ACA, the lenticulostriates would be a good place for that to diffuse. And because you've seen all these things, I would assume that they are fair game for the exam. You could get an atherosclerosis of the vertebral basilar system, and what that means is that the arteries supplying your spinal cord, man, are those things tiny, and an atherosclerotic thrombus, thromboembolism, or cholesterol embolism could certainly go into those arteries because they're right off of the vertebrals. 25% of all strokes occur in the arteries of the vertebral basilar system. And then there's this presentation of atherosclerosis that occurs within the lower extremity. And it's the type of thing that you would see in the primary care setting rather than the emergent setting most times, because it's going to present as this intermittent claudication. And whenever you see the words intermittent claudication, you need to know that what that means is that the patient is experiencing leg pain that's disproportionate to the activity they're performing. So they'll be walking and their legs will feel like they are sprinting. You know, it will be so bad that they have to sit down. It will be so bad that they will take the elevator rather than the stairs. And when they tell you this, and when they tell you that it's specifically their legs, you need to be thinking intermittent claudication as a result of the narrowing of the iliac arteries and those other arteries that supply the muscles of the leg, because those are metabolically active muscles. They're really big muscles too. So if there's an occlusion there, you're going to figure it out before you realize there's an occlusion in, you know, smaller muscles. And then some other symptoms of peripheral artery of occlusive disease that are important to recognize: decreased distal pulses, especially in the lower extremities; ulcers of the foot, this can go hand in hand with diabetes; or fully developed gangrene of the foot or leg. And now finally, there's a renal presentation, which might be very important. At some point during some question that you take during some board, they could show you a tiny kidney, and one of them's tiny and the other one's big. And they say, what's going on here? And you got to say renal artery stenosis, you know? But if they give you a lipid profile, or if they give you one of the risk factors we talked about earlier, all of a sudden, instead of just renal artery stenosis, you need to be thinking, why is that a renal artery stenosis? And the answer to that is, well, it could be a hypertensive renal artery stenosis, or it could be an atherosclerotic renal artery stenosis. So that's going to be a really big differential on boards, because that's a common pathology, you know, and making the diagnosis of, oh, this person's got kidney failure in one kidney due to a bad artery is really not that hard if you have seen the appropriate labs enough times. But figuring out why it's there, that's something that you need more than one study to be able to deduce. And so you might have to synthesize multiple findings across different parameters of lab work to be able to tell the underlying pathology behind this atrophy of the kidneys, or behind these wedge-shaped renal infarcts. That they could slice a kidney in half and show you a wedge infarct and say, well, what's the pathogenesis? And there's a lot of reasons why you could see a wedge infarct in the kidney, and one of them is atherosclerosis. So take the risk factors in the first half of this SDL to heart, because they might help you get a question or a handful of questions right later in your career. And then finally, bowel ischemia, same exact thing as we just said for the kidneys. A lot of things can cause bowel ischemia, and one of them is atherosclerosis. So make sure you recognize the risk factors and peripheral signs and symptoms of atherosclerosis, so that you can be able to differentiate an atherosclerotic origin of bowel ischemia from a non-atherosclerotic cause. So I'm going to run back through real quick and recap what I think are the exam questions for this lecture. It's important to know that the tunica intima of small or large and medium arteries is affected. I think there's going to be a risk factor question. I think it's going to be how many risk factors does the patient have? Or I think it's going to be what's the non-modifiable risk factor that this patient have? Or what's the modifiable risk factor that this patient has? And if the question is what's the most important risk factor, well, then if it's a non-modifiable, it's age. And if it's a modifiable, it's hyperlipidemia. Moving on, I think that knowing the additional risk factors, that's a possibility for a question. Just because there's 4 of them there, there's 4 answer choices. Moving on to the pathology, you're going to get a question about this. It's going to be something like, well, what should happen that doesn't happen in atherosclerosis? And the answer to that is, well, you should be giving it to your HDL, you know, but if you have a deficit in HDL or an impairment of some sorts, if you don't have enough HDL, then you can't clear the foam cells fast enough. Probably wants you to know the endothelial response to injury. I think that's particularly question worthy, that there are multiple different things the endothelial cells can do in response to injury. There's the VCAM upregulation, there's the nitric oxide decline. I don't think there's going to be a gross question on atherosclerosis-prone areas just because it's kind of easy. Hate to use that word, you know. I do think you're going to see one, probably two questions from this classification section because there's 6 of them, so that's definitely enough to get 2 questions out of. And then number 6 does have 4 consequences associated with it that would be good to work a question out of as well. And then finally, I think that it is likely that you see a question from the pathogenesis section here because there's a lot of relevant events happening in sequence at the cellular level that you ought to be able to wrap your head around. And that's it. Thank you very much for listening. As always, if you notice any discrepancies in anything that I've said, please point it out because it's going to help us both learn from it.